So a few minutes we will start.
Yes, sir. Yeah, I think we have crossed 75. I think we can start now.
Okay.
Yeah.
So good evening, everyone. Welcome to this edition of Neuromuscular Subsection 1. And today we have a very interesting theme, atypical anterior onset diseases. And the session will be conducted by Dr. Shruti Nair. She is a additional professor at Sri Chitra Institute at Thiruvananthapuram, and her team is Dr. Ashish Vijayaraghavan. He is a AP, and Dr. Gemini George. She is a postdoctoral fellow in the neuromuscular disorders. So welcome all. I hand over to Dr. Shruti to start the session. Welcome all.
Thank you, sir. Very good evening to everyone, and welcome to today's webinar on neuromuscular disorders. Today's topic is a collection of atypical presentations or atypical anterior horn cell diseases. We have 3 cases today, some of which we struggled to find answers to. And
Dr. Shruti, your voice is slightly low, I believe.
Oh, I'll increase.
Yeah, yes, better now. Yes.
So our team will discuss each of the cases along with a brief discussion on them. So to start off, I will invite Dr. Gemini, who is a postdoctoral fellow of neuromuscular disorders. She will present an atypical presentation of a relatively common cause of bibrachial weakness. Over to you, Gemini.
Thank you, ma'am. Good evening to all. Today I'm going to present the first case. My patient is a 40-year-old gentleman. The presenting complaint was weakness of right upper limb since 10 years and weakness of left upper limb since 2 years. Coming to the history proper, he's a 40-year-old gentleman from Palakkad, born out of non-consanguineous marriage. And he's not having any comorbidities. He's a toady tapper by occupation. And the symptom onset was at 28 years of age. It started as insidious onset difficulty in lifting weights overhead with right upper limb. And he also noticed thinning of proximal muscles of right upper limb. There was history of dull aching neck pain without any radiation. There is also history of twitching of muscles over right shoulder, upper back, and rarely right forearm. Weakness gradually progressed so that he found it difficult to lift even lighter weights like comb overhead. And about 5 to 6 years later, he also noticed difficulty in gripping with right hand, tearing chapati or mixing food. About 8 years later, he noticed similar symptoms on left proximal upper limb also. There was no history suggestive of distal involvement in left upper limb. There is no history of difficulty in climbing stairs, twisting of ankles, loosening of footwear. No history of craniobulbar symptoms, no sensory symptoms, bowel bladder symptoms, no history of stiffness of limbs, no history suggestive of cold paresis, no history of trauma or poliomyelitis in the past. So with these symptoms, he presented to our institute in 2018, that is about 10 years after the symptom onset. At the time of presentation, his functional status was severe proximal predominant bilateral upper limb weakness without any lower limb, or craniobulbar weakness, sensory disturbances, or any autonomic disturbances. Family history, his father gives history of progressive weakness of both upper limbs followed by lower limbs with onset at 45 years of age. And he underwent laminectomy with which there was not much improvement. And he became bedbound by 75 years of age. No further details available regarding the history, and no examination was possible as it was difficult to bring him. So summarizing, he's a 40-year-old gentleman with symptom onset at third decade, asymmetric pure motor bibrachial weakness, proximal predominant bibrachial weakness, historically LMN type, and with a doubtful positive family history. So the localization, first possible localization I would like to consider is anterior hornsel, considering the asymmetric onset as well as history suggestive of wasting and fasciculations. Then the next possibilities, localizations I would like to consider is proximal myopathy as well as motor radical or motor nerve. Coming to the examination, there was no ptosis, squint, facial weakness. Speech was normal, fundus normal. Tongue, there was no atrophy or fasciculations and the movements were normal. And bilateral winging of median and inferior border of scapula was there. Wasting of bilateral infraspinatus, deltoid, brachioradialis, and triceps present. It was more prominent on the right side. But there was no wasting of intrinsic muscles of hand, and fasciculations were noted in right deltoid and bilateral triceps. Tone was normal. About the power examination, in bilateral, shoulder muscles were weak, which was the weakness was more predominant on the right side. Bilateral supraspinatus, deltoid, adductors, flexors, then subscapularis, infraspinatus, all were weak, and it was more weak on the right side. Biceps and triceps were weak, and right elbow extension was weak, and the intrinsic hand muscles were also weak. But the predominant weakness was in the proximal hand, upper limb muscles. On examination, the neck and trunk muscles are normal. Lower limb examination was also normal. About the deep tendon reflexes, the triceps jerk was sluggish bilaterally. The rest of the reflexes were normal. Plantar was flexor bilaterally. Sensory examination was normal. The gait was also normal. So after the examination, the localization remains the same. The first possibility is still remains anterior hornsel, considering the asymmetric onset, wasting fasciculations, as well as depressed deep tendon reflexes at one segmental level. And the second localization is, I would like to consider is muscle. So the etiological differential diagnosis, among the anterior hornsel, it could be familial anterior hornsel, considering the onset in third decade, which is a slow progressive course and a doubtful positive family history. But the odd points were asymmetric onset as well as lack of lower limb involvement. Then the other one is syringomyelia, considering asymmetric weakness and wasting, but there were no sensory deficits and pure element features. Then the third possibility was facioscapulohumeral dystrophy, considering the scapular winging and asymmetric upper limb girdle pattern weakness. But the lack of facial weakness is against it. Then other possibility is LGMD like calpainopathy, considering scapular winging as well as the upper limb girdle pattern weakness. But the lack of lower limb involvement was slightly odd. Coming to the investigations, the routine investigations including CPK was normal. And the nerve condition study and EMG in the initial visit showed axonopathic process involving bilateral cervical segments. There was no evidence of myopathy in the EMG. And the MRI cervical spine plane MRI was done, which showed spondylotic changes with mild neural foramen narrowing in C3, C4, C4, C5, and C5, C6 levels, but there was no cord compression. And a muscle biopsy was done during the first evaluation from the right biceps, which showed neurogenic features. And the clinical exam sequencing did not show any pathogenic variants. This patient lost to follow for the next few years, and he presented to us in 2024 again. And the clinical examination remains the same. This is the picture of the forearm. Other than mild wasting of the right hypothenar, the forearm and intrinsic hand muscles are well preserved. And this is the examination video. We could see the forearm is preserved, whereas there is a winging of bilateral scapula. Sorry. There is wasting of the proximal muscles, including triceps, biceps, and deltoid. And the finger extensors are weak on the right side. The wrist extension also weak on the right side. The right triceps is more weak compared to the left. The shoulder abduction is also weaker on the right side. The reflexes are preserved. The triceps reflex is sluggish compared to the other reflexes. Coming to the nerve condition study, the nerve condition study, motor condition study was normal. Sensory condition study also showed normal condition parameters. And the needle EMG showed denervation and renervation potentials from bilateral bilateral deltoid, right triceps, and left flexor carpi radialis. Renervation potentials from bilateral FTI and right extensor digitorum communis. This showed evidence for chronic axonopathic process involving bilateral C5 to T1 segments. This was the MRA cervical spine repeated in 2024. It's the T2 flexion sequence and T1 post-contrast sequence showing the forward displacement of the posterior dura as well as the enhancement of the posterior epidural space. And this is the T2 axial session showing flow voids. So after the investigations and the clinical examination, our final diagnosis is it's an atypical presentation of a Hirayama disease with predominant proximal involvement. A few words about Hirayama disease. As we all know, it's caused by the ischemic injury to cervical anterior horn cell, and there is excessive forward displacement of the posterior dura during neck flexion. The disproportionate space between the vertebra and their contents, and this disproportion often results from the juvenile growth spurt. During neck flexion, the dural sac tightens, causing forward displacement of its posterior wall. And the typical Hirayama disease features include distal weakness and wasting, predominantly C7 to T1 segments, reverse split hand syndrome, then insidious onset and slow progression for 3 to 5 years, followed by a benign phase or disease arrest. Irregular coarse tremors in the fingers of the affected hand, as well as cold paresis and absence of objective sensory loss. This is the Horsham diagnostic criteria for HD, where the definite HD means the criteria 1, 2, and 3 should be met. In our patient, he satisfies the probable HD criteria, where 2 and 3 are met. Then the atypical Hirayama features include pyramidal signs like Hoffman sign or hyperreflexia. Upper motor neuron symptoms suggest serious cord involvement and predicts a worse result. And proximal upper limb weakness and atrophy is another atypical feature, which is present in our patient. Then long progression, sensory deficits, all are other atypical features described. And these are the various studies done at various centers. So in all the studies, we can say that proximal upper limb weakness have been noted in a few proportion of patients. These are the studies from India, where from NIMHANS as well as Eastern India and North India, where we could see that few patients have shown proximal weakness. And this is there is another study where we can see that proximal weakness have been seen in 2 patients which remain static, and proximal distal weakness out of the 6 patients, proximal distal weakness have been there in 4 patients. Thank you.
Thank you, Jiminy. That was a very clear presentation. This is one patient where we actually missed the diagnosis in the first time he came, but then we called him back after a while. Actually, he did not have any worsening of his symptoms. We actually called him and asked him to come back so that we wanted to know whether this is a possible diagnosis, and it turned out to be the same finding. So it was showing all the features of Hirayama in his MRI. Initially, we had thought he had a genetic anterior hornsel disease because his father had a similar story, and at that time we saw him, we were not we thought the scapular winging and all those specific involvement of certain areas of the upper limbs, that was very more likely for a genetic disease. Of course, we know that it did not fit into any known pattern of non-5QSMA. So shall we finish off the next case, which is in a way very similar to this one, and maybe we'll have the discussion together at the end of the second one.
Sure.
Jimmy, if you
Thank
could stop sharing. Yeah, thank you very much. Jimmy, can you stop sharing? Thank you. Now we come to the second case, which has around about a similar clinical presentation, but of a very far more rarer etiology. So this gentleman was 49 years old. His symptoms started when he was 45 years old. He also had asymmetric weakness of upper limb starting on the left side and then going on to the right side. So about 4 years back, he noted that he had difficulty in raising the left upper limb overhead, particularly when he was trying to remove light bulbs as part of his job. And over the next 3 years, it progressed to the extent that he could not raise it above his shoulder. And about 1 year after he noted the weakness on the left side, he started noticing some problems with his right side. So he noted elbow flexion weakness at the time. He could not bring food to his mouth, and he needed to slightly support it with the opposite hand when he was having food. He did not say that he had any shoulder weakness, but on probing after examination, he is told that he also has similar weakness on the right, but not as bad as on the left side. He also had noted thinning of muscles around his shoulder, first on the left and then on the right. And since the last 2 to 3 years, he also has occasional fasciculations, like twitching of muscles over confined to the arms and forearms. He has always had a neck pain since the last 12 years, which was very mild. There was no limits phenomenon or any other radicular nature for the pain. He never had any sensory symptoms, bladder symptoms, bowel symptoms, no cranial musculature involvement, no systemic symptoms at all. Past history was relevant for a single episode of a road traffic accident. This he had about 12 years back. He was riding on a scooter. He was hit by another vehicle and he fell backwards, hitting the back of his head and neck. He remained unconscious for a few hours. He was imaged at the time from a nearby center, but did not need any long-term hospitalization. But thereafter, he has told that he has noted the neck pain, which has become more and more prominent since the last 5 years. He had no other comorbidities. Family history was not very significant for anything. So on examination, he was a very tall guy. He was 6 feet 2 inches tall. The arm span to height ratio was normal. The height to neck length ratio was also normal. He had a high-arch palate and long tapering fingers, some hypermobile joints, but there were no other signs of Marfan syndrome. On examination of the neurological system, his cranial musculature was normal. The motor system showed wasting of the periscapular muscles, the pectorals, and the arm muscles, not forearm, sorry. And there were no fasciculations which we could see. There was no scapular winging. The tone was normal in upper and lower limbs. So on examining the power, his neck was normal, flexion and extension were normal. He had an asymmetric weakness of the periscapular and the arm muscles with preserved power of wrist, hand, and intrinsic muscles. Lower limbs were also normal. So you could see that the weakness was predominantly involving the supraspinatus deltoid, external internal rotators of the left side, and biceps and triceps. On the other hand, the similar pattern of weakness, but with the lesser intensity on the right side. He did not, we could not elicit any reflexes in his upper limbs, but his lower limb, knee jerk was brisk, which looked normal to us, and ankle jerk was also normal. The plantars were withdrawal. There was no suggestion of an extensor plantar. Abdominal reflexes were spared. The rest of the examination, including sensory examination, gait, skull and spine examination, were normal. So I'll just show you a few of the signs. So you can see that he has severe weakness of the shoulder abductors. On the left, slightly better on the other side, right side. So biceps is weak. You can see it's nearly symmetrically weak on both sides. And the wrist extensors, they are normal. Flexors are normal. So the hand grip as well as intrinsic muscles were also normal. And this is checking for the reflexes. Okay, the reflexes were absent in the upper limbs. Wait. So what we had here was a patient who had severe asymmetric proximal upper limb weakness with sparing of the distal upper limbs, neck, the axial system as well as the lower limbs. It was a element kind of weakness. There was no evidence of any extramotor involvement. This is the typical man in barrel syndrome. So when in this patient, the clear cut, our localization was to the anterior horn cells because he had an asymmetric onset, fasciculations, wasting. There is no specific tendency to involve any group of muscles and is confined to a certain territory without involvement of lower limbs or any specific selective involvement of muscles. So overall, the localization was anterior horn cells, and we of course thought about the flail-arm variant of motor neuron disease. He was quite a young person to have MND. He was only 49, and onset was at 45 years of age. Hirayama was considered, and then soon we did not think the age was at all correct for Hirayama. So you need the onset to be somewhere in the adolescent period to actually call it as Hirayama. And he was very clear about the onset of the illness. And of course, other possibility is a ventral myelopathy. The anterior spinal artery syndrome can produce bibrachial weakness without sensory, but that of course occurs as an acute event. And the rest of the presentation of the DDs which I've put generally do not come in the manner which we get. So there have been cases of paraneoplastic myelopathy and myeloradiculopathy, but most of them have some sensory involvement. And they, of course, last for a few months rather than the 4 years which our patient presented with. Another consideration is a bilateral brachioplexopathy or bilateral C5-C6 radiculopathy, although they are not at all common, especially bilateral radiculopathies in the cervical region are unusual, but they are actually common diseases. So you can have atypical presentations of these diseases. We would have expected sensory, we would have expected pain, but this was something we had to rule out. Muscle, of course, there are a lot of muscle diseases which have scapuloperoneal presentation and which can start in the shoulder girdle, but almost invariably they have additional lower limb phase, axil, some other system involvement. So without any other area being affected, only the shoulders being very severely weak is unusual for muscle disease, especially if it is a genetic one. Of course, you can have variants of inflammatory muscle disease which can be very focal, but in this patient at 4 years history, that was not a big consideration. Neuromuscular junction, again, myasthenia gravis has been reported to be an etiology for man-in-barrel syndrome. Again, a common neuromuscular disease, but this presentation would be extremely rare. Examination did not support that diagnosis. Of course, one a very common cause for man-in-barrel is a bilateral ACMC watershed infarct, but here he had an element syndrome, not a UMN syndrome. So his nerve conduction studies were normal, including the sensory studies, but we found that there was profound neurogenic changes involving not only the proximal muscles of both upper limbs, so biceps, deltoid on both sides were showing profuse denervation, but there was also denervation somewhat spilling over to the forearm and the hand muscles, although they were not weak on clinical examination. The paraspinals, we had sampled 2, and one of them showed denervation. The thoracic paraspinals and lower limb were not affected. So it was confined to the cervical myotomes. And there was definite involvement of a proximal segment. The investigations, the routine ones, were normal. CPK was within the normal limits. Echocardiogram had showed a mitral prolapse. This was in tune with our thought that he had a Marfanoid habitus, but rest of the basic investigations were all normal, including ENT and ophthalmology assessments. Now, at this point, we did not have any features of a diffuse anterior horn cell disease. So we, of course, wanted to see how the spinal cord looked like. So what you can see here is the sagittal MRA, which shows a hyperintensity, which is coming from C3 to at least C5 level. And you can see our typical outside or snake eye appearance, indicating the hyperintensity of the anterior horn cells in the axial section. And this is not very well seen here. There was also an atrophy of the cord, which extended from C3 to C6 levels. There are some degenerative changes of the spine, but that is not obliterating the CSF space around the spinal cord. And we, of course, looked at the Hirayama study. There was no engorgement of the epidural plexus. There was no anterior shift of the dura, and there was no contrast enhancement, which was suggestive of a Hirayama in this patient. But what was striking was a brain MRI. We could see some gliosis in the cerebellum, but these are the SWA images, which show that there was pluming, which was seen in the vermin region of the cerebellum as well as the cerebellar folia. And in GR images in the spinal cord, this extended till the conus. So that is not, it is not as dramatic as you see it in the brain, but there is a hemosiderin deposit which is seen in the spinal cord as well. And when we looked closer at the spine imaging, which was the first one which I had seen, you can see that there is a thin line which is coming in front of the spinal cord, and I have tried to point it out using yellow arrows. You can see that thin line represents that this is a subarachnoid space between the spinal cord and that thin line, and this is that dark line is a dura, and beyond that is the epidural region, and there's an epidural collection of CSF, which is very prominent. You can see it also better in the axial images. So in the anterior part, you get a dura as a line, which is marked by a yellow marker, and in front of it, there is a dural collection. It is very prominent lower down. So this is a section from a lower part. So what you had is called as a ventral longitudinal intraspinal fluid collection. So this is often associated with intracranial hypotension. So this is actually a leak of the subarachnoid fluid into the epidural space, but we did not have any features of intracranial hypotension in the brain imaging. So essentially what we had in this patient was a guy who presented with bibrachial proximal amyotrophy, and imaging showed a ventral longitudinal epidural CSF collection and infratentorial and spinal superficial cirrhosis. And we had a background history of head trauma, and on examination, a Marfanoid habitus without all the full clinical picture of Marfan syndrome. So now what is the common thread among all these? So when we did the literature search, we found that there are a few conditions which are closely associated. So you have superficial cirrhosis, intraspinal fluid collection, and bibrachial or multispinal amyotrophy of limbs. In addition, intracranial hypotension and spinal cord herniation. So these 5 conditions have been reported in different combinations, and all are connected by what is known as a duropathy or a dural defect. Essentially, a tear in the dura which allows the spinal fluid to leak outside. Now, what causes a dural defect? The commonest cause is a trauma or a surgery. It often is seen around a place where you have a disc ossifier complex or even a herniated disc. So that is also considered as one of the causes of it. And of course, in people who have dural ectasia, as in Marfan syndrome and Ehlers-Danlos syndrome, they are more prone to having dural defects. And what happens when you have a dural defect is that the CSF seeps from the subarachnoid space into the epidural space. And this leads to a longitudinal collection. This is a case from literature which looks pretty much similar to our case. There is an anterior epidural fluid collection. It can also produce a herniation where the spinal cord itself herniates. That is known as a ventral herniation of spinal cord. And as you have a leak ongoing, it produces intracranial hypotension. And of course, it also produces spinal cirrhosis in a way. And the reason for that is there are 2 hypotheses for why spinal superficial cirrhosis occurs when you have a intracranial hypotension. One is that there is when the fluid is leaking into the epidural space, the fragile blood vessels in the internal venous plexus there gets repeatedly ruptured, producing bleeding into the subarachnoid space. Or because of the craniospinal volemia, hypovolemia, or rather the venous sinuses get engorged and they tend to bleed out. So these are the 2 hypotheses they give for co-occurrence of superficial cirrhosis in these patients. And it has been shown that about 10% or so of all patients with intracranial hypertension have a superficial cirrhosis. Okay, so of course, superficial cirrhosis occurs due to recurrent bleed into the subarachnoid space and cannot occur with a single trauma alone. It has to be an ongoing occurrence for it to be a worsening situation. Now, the definitive management is possible only after you can find where the dural leak is occurring, and for that you require a myelogram. You can either do a CT myelogram or a MR myelogram, but the best procedure would be a dynamic CT myelogram. That is by taking a CT myelogram while changing the position of the patient and acquiring rapidly multiple images, so that even if it is a fast filling kind of a defect, you know exactly where it starts, exactly at which point the leak starts. So the ideal imaging would be a dynamic CT myelogram, and with MR, dynamic imaging is not possible. Now, why does amyotrophy occur at all in this condition? So that we have a dural leak, but why does it lead to an amyotrophy? And that continues to be $1 million question because we do not know the answer yet. So the most accepted reason is possibly a venous congestion. So you have a situation where there is a compression onto the spinal cord, and that produces a congestion of the venous plexus as well, and that leads to venous ischemia of the cord. And there are a few supporting evidences for that. One is that there have been animal studies where they've replicated the similar situation, and after autopsy they find that the venous engorgement is the causative factor. And they have also postulated that the venous compression is easier to achieve. Rather, you can do it at lower pressures than arterial ischemia, which is the other postulate. Some papers have told that it is dynamic compression of that collection itself onto the spinal cord. But in most situations, you find that the compression is not that bad that it can directly compress onto the cord. And why it then prefers only the anterior horn cells is again a question. And very, very good papers have also postulated motor root dysfunction. They tell that when the dura is compressed, the roots which are tethered to it are pulled, and that leads to a conduction block. But this does not stand up to scrutiny, because you know that there are visible changes in the anterior horn cells in the MRI, and electrophysiology also usually supports the anterior horn cell pattern of involvement. And then why the anterior horn cells, why in this certain regions, why proximal involvement, why distal involvement in certain cases. This is something which has not been properly understood. So the vulnerability of anterior horn cells at certain region has been proposed. So there is a proposal that between C3 to C5, there is less collaterals of the venous system. And that is one area where you can have venous ischemia. But we do not know that, we do not have good data to support that. So just to show you all the conditions where you have a disease which is compressing the spinal cord. So what should be technically a myelopathy, but it produces an anterior horn cell involvement. So we have the ventral longitudinal intraspinal fluid collection. Of course, we have the Hirayama disease, and of course, the dropped level in case of a compressive myelopathy, which has been classically described with the foramen magnum compression, but you can also get it with mid-level compressions. So in all these situations, it is not the same site that is always affected. So in the intraspinal fluid collection, you tend to have proximal involvement, whereas Hirayama and compressive myelopathy typically affects the distal segments. Just a few words on the notorious mimic or the main situation we need to differentiate, which is the Flaylam syndrome or the Walpian syndrome, which is a variant of motor neuron disease. Here you get asymmetric more than symmetric proximal upper limb weakness and atrophy. Although there are additional human usual soft signs are there, because of the severity of involvement, you may find that all reflexes are absent. But then lower limb may show subtle breast reflexes. And the other googly in this is that it has a very slow clinical progression compared to the routine ALS. It has a very slow clinical progression. And even at the end of 3 years, a quarter of people may only have upper limb involvement. So that is why it needs to be kept as an important differential diagnosis. Now, the point which helps to differentiate is that MRI spine for normal, for mortals like us is normal. Of course, higher end studies like with 7 Tesla and all have shown abnormalities, but they do not show the typical snake eye pattern. Now, how do we manage the patient? This is the primary cause is a dural leak. So we have to determine that. We can start with a CT myelogram or MR myelogram and see whether we can find the dural defect. If the defect is detectable, we can go ahead with the surgical repair of the defect. And it is recommended that it is done because if it is not done, the patient can continue to develop intracranial hypotension, especially for this patient. He currently does not have any features of intracranial hypotension or cirrhosis, but he may continue to develop that if we fail to treat it appropriately. And papers have shown that even quite late into the illness, when the amyotrophy looks very serious, even those patients, if they are intervened surgically, they may have some reversal of the weakness. So the point here is that the ventral myelopathies are a very important differential diagnosis for bibrachial amyotrophy. So we need to be a bit vigilant about what we look for in the MRI spine. We can also keep our eyes open for the possibility of superficial cirrhosis and also ask the history which can pertain to that. These are common associations, but need not be present in all patients. So just because you have a dural defect, you need not have intracranial hypertension. And if you don't have that, that part need not be managed either. Thank you.
Excellent cases. I mean, both look exactly like any atypical anterior horn cell, and both were actually treatable. I mean, even Hirayama can be stabilized by doing that anterior compression, decompression. Acha, in this second case, you could detect the site of the leakage.
No, actually, we initially discussed and we were told that dynamic CT is required, CT myelogram is required, and we did not have the facility. So we sent him back. But now that I've read up whole thing, I think we should first do a routine myelogram and then see whether we can detect it or not. So we'll call him back in 1 week or so, and we'll get that done. So we have not done the myelogram yet.
So good.
I think there are 3 questions in the chat box.
Yeah.
So first question is, how important is it to get a contrast MRI in Hirayama disease? Gemini, would you like to take that? Okay, then I'll go ahead. Okay, Gemini is there, yeah. Gemini, what is your recommendation for MRI in Hirayama disease?
The preferred MRI is MRI cervical spine with flexion images and contrast.
I think contrast is essential because, otherwise it's a presumptive diagnosis. There are sufficient mimics so that, sometimes the migration of dura is not, anyway, the presence of anterior horn cell hyperintensity is not sufficient because there are so many mimics for that. So you need to show that anterior migration of dura and the epidural venous plexus getting enhanced. So these two are absolutely required. So I would strongly recommend a contrast MRI, although it is possible if in a very, very classical scenario, if you want to avoid that, that's fine.
Madam, I think this is a common mistake which is done while prescribing the MRI in these patients.
I fully agree, sir.
So, there's either some more.
Madam, one more. What are your comments about the preserved reflexes in the first case?
See, in anterior horn cell disease, I don't think there is any need for the reflexes to be lost, except for SMA, of course. It is directly usually proportional to the level of weakness that the patient has. And in addition, this is actually a myelopathy. You may get features of myelopathy even when you have, moderate weakness, which looks like a lemon to us.
Because in Hirayama, we usually take the depressed reflexes as the rule.
We do get, but there is no absolute rule which states that it has to be low. I personally think that, the presence of some subtle UMN signs are very often seen.
I think in the human science in Hirayama has been grossly overstated. If you see, and more, I'm more and more surprised if you don't get a little more brisker reflex in the lower limb in Hirayama. So somehow it is an ischemic myelopathy. I mean, I think Hirayama is also a duropathy. It's all come into the same picture. We don't know the exact cause for duropathy, but I don't know how if you do a flexion MR in a similar 100 or same age and sex matched flexion MR patients in this one, and if you see 10% of those who have the same changes and you don't have myelopathy, no evidence of Hirayama disease. So how will we interpret it? That has always been my this one. How many studies who have a control population doing a flexion MR and shown that there is these changes occur only in Hirayama disease?
I agree with you because I have seen a few where
Yeah.
I thought there was an anterior migration, but I think so this is actually something which occurs during normal development. No, so one of the hypothesis that there is an asymmetric growth of the spinal cord versus the spinal vertebral system, and I suppose it may be there in others as well.
Yeah, there are classical Hirayamas without having this MRI changes are also there. So we have the textbook picture of Hirayama disease is there, and we still don't get the MRI findings. The reverse is also there. So, but overwhelmingly, we see these changes in Hirayama, where this is the cause or the effect. I mean, that is also a little difficult to say at this point of time. I know Nalini madam will kill me if I say anything of that sort, but still, I have some ideas. So let's see. Some hypothesis is there whether this is there or not. So that's coming to from that different. Let's go to the first case. The first case was very interesting. So imagine the first case. The father has the same disease. So if you see in the case, and you see that he also has the same disease. So what I want the fellow to answer. So what would you have thought of this disease? You examine the patient and is exactly the same phenotype as that of the patient. Do you have any genetic syndrome in your mind? Gemini is there.
Yes, sir. Sir, few cases of genetic familial Hirayama disease also have been reported in various studies.
You
But-
don't diagnose Hirayama from the proximal weakness, no, first time. Your first diagnosis is never Hirayama. Okay, you see the MR, you see the lot of things, you come back to an atypical presentation of a common disease is never the first diagnosis. So Hirayama is, but otherwise your first diagnosis is bibrachial amyotrophy, right? So that's your first diagnosis. A familial bibrachial amyotrophy. What will you think of first? Do you think any of these presentations have been reported before?
Non-piquous SMA, sir.
So odd one has been reported in bibrachial amyotrophy, familial bibrachial amyotrophy, but you have done whole exome, you didn't, it is negative. That's what you
Yes.
told, right? Yeah. So,
Yes.
but that could be if it is a father is having a similar disease, but the age of the father is also too odd for an SOD1 mutation to develop. That is also little later onset. It's also there. So that's interesting.
Overall, they never behaved like familial ALS.
Hmm.
It has been stable for 10 years now.
Yeah.
So yeah, so behavior is not as ALS.
That is
So
also
I
very similar.
so I hunted a bit for anything, any genetic motor syndromes like motor neuronopathies other than ALS.
I
And
still believe Hirayama is a genetic condition. I think there is a gene involved in something involving the dura. Something involving the dura. It's a duropathy. Something involving the. I mean, it's too. I mean, it's too widespread a disease across the world to develop in only in males predominantly. Such a widespread. If this male to female ratio is still out of proportion to what we see in any other disease, right?
but that again is actually attributed to the
Yeah, I
rates of
understand
growth. Yeah, yeah,
to the
in males and
growth spurt
females.
is, but I mean, growth spurt occurs in males in many other conditions, not just in this is not only in the cervical spine. So a lot of things are there. See, I don't know. I think there is some pentanucleotide or hexanucleotide repeat somewhere hiding behind to show them.
There is one, no, there is one reported, I think.
Yeah.
There is an ORF, C5 ORF
Yeah,
or something
something.
that has been
There is
reported.
one
Yeah,
RF
yeah, yeah.
reported, but it has been searched in other Hiramas, which they didn't find it, but something is there. So that's something interesting to say. There are some other questions also in the
Yes.
Shruti, any
chat.
reason that second case never had any symptoms of intracranial hypertension despite having a type 1 kind of a leak?
No,
Used to
no,
be a
no.
massive leak.
Yeah, yeah, yeah. So that is what we asked him again. So he has neck pain, but he has never had a headache, significant headache. And MRI was also, we went back and checked, there is no evidence of intracranial hypertension. But this is actually not uncommon. In the reports, they may or may not have intracranial hypertension, but they may eventually develop it over time if you don't treat it. They may go on to develop intracranial hypertension. And
The second case is something which if you don't, this is something if you don't know, you will never die. You know, unlikely to diagnose also. If you don't specifically look for it, easy to miss in the MR. When you see, look at the benign way. So ALS, any review article on ALS variants, this will be there. This dural, this intestinal fluid, this is there. We think it is okay. This is usually go to the surgeon. We will not see. So then something that we see, surgeons may be seeing more. I don't know because post trauma, this one will be. But this is something which I think if Shruti madam has not put up an arrow, I know I don't think many of us would have picked it
Yeah,
up. Also
yes,
picked
yes.
it up
But
also.
Vishnu,
Uh,
Dr. Vishnu,
yes, sir.
this could also highlight that maybe in all the cases of biobrachial involvement and such involvements, in all the cases, the dynamic MRI is must. And we should look for these conditions also.
Yeah. So sure.
Although not
I
although
mean,
rare, but they are treatable, right?
and there is, but on the other hand, I strongly resist the tendency to label every bibrachial weakness as Hirayama also. There is a general tendency to now, because it is considered to be treatable, now to somehow make it into a Hirayama and try and treat it. So there is, there are some cases of pure Hirayama is there, but every bibrachial weakness is not Hirayama. So that is also, is a very strongly that should be emphasized that.
One more answer is needed in this clinical scenario. I think the Nemans would give the answer. What is the impact of surgery in these cases and what are the outcomes?
Nimans won't give the answer. Nimans can give the answer only if they do a randomized control trial. If you
No,
don't
but
do a
even
randomized control
even
trial,
even if observational cohort, it will give some indication, right?
how can you give the indication? If the
Yeah,
disease
At
is
least
you're right.
self-limiting, if the disease is self-limiting, and if I say that if I do the surgery and patient disease, I'm saying it disease limited by itself,
But
not
it's
because of
self-limiting,
surgery.
it's not self-improving, no.
No,
So
that's
maybe they show
improve.
improvement.
Yeah, improvement. That's something which needs to show. So
Yeah.
Yes, right, agreed.
Yeah.
Not
So
only
I
there
think
valid.
there
are
is,
two more questions.
I think there is that question is whether surgery, what is the clear evidence? We don't really have a clear evidence, but I think that there is a good way of looking at the pre and the post cohort, or the sense that if we have a natural history cohort, and we can pick up the level of disability that they reach, and the surgical cohort can also be followed up. Unless apart from doing an RCT, if
See
we get a matched cohort,
what we can say is Nimans has given us a very good observational cohort for
yes,
surgical benefit. They have pushed the case for a push the case. No ethics committee can now refuse an RCT treatment. They have a strong case for doing an RCT. Absolutely strong case. I mean, if the amount of benefit that madam says is there, sometimes some cases she says up to 80% improvement. You need a sample size of 20 patients. That's all you need to do an RCT if you want to say it in RCT. I mean, nothing prevents anyone from doing. We all see Hirayama. I don't think anyone else is there who doesn't see a 20 case of Hirayama probably in 6 months. Everybody sees. Anybody can take up and do an RCT with the surgeon and do it and show that this has got the amount of benefit that we are showing. My worry is if you do a blinded RCT and do it, you may show some arrest in improvement. If you have to show and whether that improvement has to be shown in an RCT, then it's a class 1 indication. Nobody should refuse the surgery. All patients should get surgery.
But the key factor in that RCT would be when the surgery is done.
That's if when
Maybe
you
the
have
first 3 years from the onset, maybe first 2 years of the onset.
see that
Otherwise,
depends.
after the surgery is done after 5 years or 6 years, it makes no point.
So
Yeah.
these are all
The
questions.
very
These are all,
specific indications to take up the patient for surgery also. Not all patients require surgery.
I mean, these are all. How do we know? Nalini madam will come and say that I have done surgery in a patient with 10-year history and still he has improved. Still improved. Somebody is, for example, your dural tear case, which is there for 10 years. If you repair the dural tear, you're only told that after 10 years also there are cases, long-standing cases, patient has improved. So how can you not give the benefit of doubt to those patients if the surgery is improved? We have to include, I mean, we have to do a different subgroup analysis, whatever you do it and show that the surgery cases can improve. I think Chitra should take it up and do it. Even in a small trial is happening in AIMS also. So I'm not involved, but someone is doing it. But somebody has to do it and show that this makes an improvement. And in our country, we have so many cases. If this Hirayama was very common in US, they would have done it by this time.
Yeah, that's true.
This is a disease of ours, and we lament that we don't do anything in this one. We all can do it. Nothing prevents from us from doing this small trial. This is easily, you can publish it in any JM. So it's all up to you to do it.
Role of blood patch, Dr. Shruti.
Yeah. So actually, we had spoken to the. There is very little data on it. Most of the, blood patch is useful or mentioned as a useful thing only for intracranial hypertension. It is not mentioned as a treatment for the amyotrophy part of it. So none of the case reports or case series show that blood patch has been tried. So I think we cannot. We do not know whether it is useful at this point. So they all recommend surgery in this situation. One patient we actually recommended that. We recommended was because another patient with similar story, and he did not want surgery, and we told that we recommended that to him, but he has yet to give his consent for the procedure. So we will know that also.
Your second case shows that it's a long-standing disease, no?
Yes.
You need to find that thing because I don't know whether the blood patch can immediately permanently arrest that thing which is there for such a long period.
If we find a single area, maybe.
Yeah.
I don't know if multiple areas or something, we do not know whether blood patch should be tried at all.
Yeah,
And one more question is whether the first case, cervical dural AVF, was ruled out. So we did not do a DSA for him, but the T2 did not show any evidence for a flow voids in the subarachnoid region. So no, we did not think there was a dural AVF after discussion. So now, thank you very much for the discussion. Shall we move on to the third case?
Yes.
Ashish, it's over to you.
Thank you, madam. I'll present the third case, an ophthalmoparatic anterior hornsel disease. A 67-year-old man with presenting complaints of drooping of eyelids for 6 years and difficulty in breathing for 1 day. Patient had history of fluctuating ptosis with diurnal variation and intermittent diplopia over the past 6 years. He was unable to move his eyeballs smoothly, forcing him to turn his head sideways to focus on objects. He was diagnosed with non-thymomatous ocular myasthenia, AChR antibody positive, and was treated elsewhere with pyridostigmine and oral steroids. He was irregular with his medication. He had partial symptom relief with treatment, but discontinued the medicines after a year due to side effects. His ocular symptoms were persistent. However, he was ADL independent. He could practice as an advocate. He could go to court. And 2 years later, he developed sleep disturbances in the form of loud snoring at night and excessive daytime sleepiness. There was no history suggestive of REM sleep behavioral disorder. He presented to us with worsening of ptosis 6 years later. Still, he was not on any medications. He did not have any bulbar or limb symptoms. He was advised admission because he had some atypical features on clinical examination. And while awaiting admission, he developed respiratory failure and had to be intubated and mechanically ventilated. So this is his video. In the initial part of the video, you can see that there is no ptosis. Eyes are wide open. And on testing for eye movement, the eyeballs appear to be completely frozen. And there is fatigable asymmetric ptosis, right more than left. He also had fasciculations in the arm. In the shoulder region. Wasting of the intrinsic muscles of the hand with mild weakness. And polymyomiclonus involving both upper limbs. He did not have any features suggestive of Parkinsonism. There was no postal instability. Deep tendon reflexes were brisk. He did not have spasticity, and plantars were flexor. So summarizing the clinical findings, he had asymmetric fatigable ptosis, complete ophthalmoplegia with intact vestibulo-ocular reflex, which could not be demonstrated on the video, and he had reactive pupils. He had asymmetric wasting and weakness of intrinsic muscles of the hand, and posterior fibers of deltoid with diffuse fasciculations in the trunk, upper and lower limbs. DTRs were brisk without any spasticity. No facial or bulbar weakness or tongue fasciculations were noted. So localization for the fatigable ptosis with diurnal variation is the neuromuscular junction. And for the supranuclear component of gaze palsy, probable brainstem involvement or above. And fasciculations and wasting when the patient was not on any medications, probably anterior hornsel. Moving on to the investigations, his nerve conduction study was normal. EMG showed active denervation and chronic reinnervation in both cervical and lumbar spinal segments. IcePac test was negative. RNS was negative. Jitter study with concentric needle showed abnormally prolonged jitter from facial muscles. AChR antibody was positive, done by LASR technique, and MuSK antibody was negative. MRI brain and cervical spine was normal. CT thorax was negative for thymoma, and paraneoplastic antibodies were also negative. So this case had atypical features for a myasthenia gravis. He had wasting fasciculations, brisk DTRs. EMG showed evidence of motor neuronopathy. So anti-Iglon 5 antibody disease was suspected in view of sleep disturbances, fasciculations, wasting, oculomotor findings, especially the intact VOIR, which is not expected in a case of myasthenia gravis or an anterior hornsel disease. So we investigated specifically for the disease. CSF routine analysis was normal. Serum and CSF antibody titer for anti-Iglon 5 antibody was strongly positive, And the cell-based assay showed strong fluorescence in the transfected cells here, indicating the test is positive. And HLA-DRB1 and DQB1 was also positive. And the video polysomnography was suggestive of fragmented sleep, moderate obstructive sleep apnea with frequent arousals and limb movements. MRI cervical spine showed only degenerative changes, and MRI brain was also normal. So the diagnosis here is coexistence of myasthenia gravis and Iglon-related motor neuronopathy. So he was treated with 5 sessions of plasma exchange followed by intravenous immunoglobulin and 2 doses of rituximab. He was weaned off from ventilator and started ambulating gradually. Pyridostigmine 180 mg daily and tapering doses of oral steroids were continued, resulting in significant improvement in his overall condition, including the dyspnea and hand grip, and mild improvement in ptosis. There was no further progression of muscle wasting or weakness or fasciculation at 6-month follow-up. However, 6 months later, the patient succumbed to aspiration pneumonia-related systemic sepsis. So, anti-Iglon-5 disease frequently presents with supranuclear gaze palsy, resembling that seen in progressive supranuclear palsy. While ptosis is also reported, it differs from myasthenia gravis by being non-fatigable and is not associated with diurnal variation. And myasthenia gravis can be associated with other autoimmune disease in around 12 to 22% of cases in different case series, with highest prevalence observed in females and those with early onset myasthenia gravis. And molecular mimicry is one of the potential mechanisms for this association. Anti-Iglon-5 antibody disease is mediated predominantly by the IgG4 subtype and less commonly by IgG1 subclass, whereas AChR is predominantly IG1 and sometimes IgG3. So the treatment differs for IgG4 type of disorders. Plasma exchange and rituximab injection would be the way to go. So some of you might have some questions at the end of the case. Did the patient have myasthenia at all? Yes, the patient did have fatigable ptosis with diurnal variation from the onset, and AChR antibody was positive. The second question would be how much of respiratory failure in this patient was contributed by myasthenia and how much by ALS? We do not know, but the patient had a respiratory infection triggering the triggering the respiratory failure. So probably there's a component of both here. And the other question would be, does myasthenia occur as a paraneoplastic manifestation of Iglon-5 related tumors? No. Here, malignancy associated with Iglon-5 antibody is quite rare, around 10 to 15% only. And thymoma has not been reported at all. In a large series of comprising of 53 patients, only around 15%, 8 patients had malignancy. There are 2 different malignancies. None of them were associated with thymoma. So, coming to Iglon-5 antibody related disorders, next few slides will be on Iglon-5 antibody related disorders. The disorder was initially described in 2014 by the Barcelona group, Lydia Sabater and Carlos Gage et al., where they described 8 patients with sleep disorders, mainly the REM and non-REM parasomnias and sleep disordered breathing. Later on, more symptoms were described in this paper by Carlos Gage et al. Again. Apart from sleep disturbances, bulbar symptoms, gait instability, dysautonomia, and hypokinetic and hyperkinetic movement disorders, cognitive dysfunction, and oculomotor findings were described. This is probably this article from Brain by Grutter et al. From Germany, from the Generate cohort, is probably the largest series, where they found out that the mean age of presentation was around 64 years with a range from 40 to 82 years, indicating that the disease is a disease of elderly, and time between onset of symptoms to diagnosis was roughly 3 years, with almost equal sex predilection. 28% of patients had a subacute disease and remaining had an insidious onset chronic progressive disease. Only 21% had isolated syndrome, others had multi-system involvement. And first-line immunotherapy resulted in improvement in 41% of patients, and early initiation within the first 6 weeks was a predictor for therapy response. Low pre-treatment neurofilament light chain was also a significant predictor for a better outcome in this particular study. So in their study, brainstem syndrome was the most common involvement, followed by sleep disorder. The study from Spain showed that almost all patients had sleep disorder. Here only 51% had sleep disorder. Brainstem was the most common, followed by gait disorder. And here they have clearly described that fasciculations were seen in 34% of patients. And they had clinical evidence of fasciculations and cramps, as well as electromyography findings of fasciculations. And other findings were cognitive dysfunction, hypokinetic and hyperkinetic movement disorders, and autonomic dysfunction. So there is a controversy on whether the disease is neurodegenerative or autoimmune. There are more points supporting an autoimmune pathogenesis, such as robust association with the various HLA haplotypes seen in 60% of patients, and autopsy studies showing absence of neuronal deposits of tau in some patients, and antibody studies demonstrating that they cause irreversible internalization of Iglon5 and induce cytoskeletal alterations in cultured rat hippocampal neurons, and presence of CSF inflammatory changes and partial response to immunotherapy in patients who were initiated on treatment, especially in the early stages of disease. And in 2021, the same group have given 5 clinical phenotypes, namely sleep disorder, bulbar syndrome, movement disorders including a syndrome resembling PSP, cognitive impairment, and neuromuscular manifestations with muscle weakness, atrophy, and fasciculations. So MND-like presentation of Iglon5 has been reported before. So in this particular study by Werner et al. From Germany, they identified 5 patients who were Iglon5 positive and had a bulbar onset MND-like phenotype. So these patients were severely affected by bulbar impairment and its respiratory consequences. Sleep disordered breathing and parasomnias were common. All patients showed clinical or electrophysiological signs of motor neuron disease without fulfilling the diagnostic criteria for ALS. And one patient regained autonomy in swallowing and eating, possibly related to early initiation of immunotherapy. The journal was published in Neurology, Neuroimmunology, and Neuroinflammation. And this particular study, unusual association of amyotrophic lateral sclerosis and myasthenia gravis, a dysregulation of the adaptive immune system, was published in Neuromuscular Disorder Journal. Here, this was a multi-center study comprising of 18 centers from France. Over a 12-year period, they identified 7 cases of patients who had ALS and myasthenia. And in 3 cases, myasthenia gravis preceded ALS, as in our case. And this association may be triggered by a dysfunction of adaptive immunity, is what they have postulated. Another study, this study is from China, where they say that the coexisting autoimmune diseases in myasthenia gravis is around 12 to 14%, and autoimmune diseases occur more in females and seropositive myasthenia gravis patients. Autoimmune diseases preceding ALS, an epidemiological study, was published in the Neurology Journal by Turner et al. This study is from UK, where they identified that significantly more cases than expected of ALS was associated with the prior diagnosis of asthma, celiac disease, young onset diabetes, multiple sclerosis, myasthenia gravis, and other systemic connective tissue disorders. And this association raised the possibility of shared genetic or environmental risk factors. However, coexisting autoimmune disease with Eglon-5 antibody-related disorders are very rare. There is a single case report of anti-MOG antibody-related disorder, single case report of anti-LGI1 associated encephalitis, and another case report of anti-GABA-B associated with Eglon-5 antibody disorders, and this case, and our case, which is associated with AChR1 antibody. So as of now, there are very few case reports of coexisting autoimmune diseases with the Eglon-5 antibody disorders. So the case is unique in two ways. First of all, Eglon-5 antibody related disorder presenting with ALS-like phenotype is very rare, and that too occurring in a patient who already has myasthenia gravis, ocular myasthenia, is even rarer. So the learning points from the case, Eglon-5 antibodies should be tested in patients with atypical presentation of ALS, especially when associated with sleep disorders or eye movement abnormalities. Thank you.
Thank you, Ashish. It was a great case. And I think that it was actually the clinical examination of that intact VOR that led to the you checking the antibody in that ICU.
Yeah.
Because overall, his myasthenia had not significantly worsened over the time. So I think initially the question was whether it is ALS or whether it is pneumonia which caused the respiratory distress. And even the treatment did not affect the myasthenia much. The eyes were remaining pretty much the same, I think, even on follow-up.
Yeah.
I want to know who checked first for the VOR.
I think Ashish only did it.
Who picked the VOR? He should be given credit. In a myasthenia patient, antibody positive, frozen eyes. Somebody check
He had wasting and fasciculations was.
Okay.
So then we thought that like he did not complain of fasciculations or weakness of the hand.
No, that clicks the diagnosis. No, so that's the crucial part. So
Specifically looked for VOR.
Yeah, very. I mean, that's a classical side of where your clinical neurology trumps everything else. So somebody picked that up, so that's why you could make a diagnosis easily to make a diagnosis. My query was, does peripheral neuropathy occurs in Eglon-5? Because that is the only neurological manifestation which is not there in the table. The rest of everything in neurology is there. But you look at Eglon-5's neurological manifestation, you can virtually do it for any neurological, rapidly progressive or subacute, any neurological condition, almost anything you can put it up.
Wonderful case. Did you plan for thymectomy in this case?
No. The patient was 73 years and thymoma was not identified.
So thymoma may not be advised. Suppose this patient would have been young, 73, fine. But suppose this patient was young and you are treating myasthenia gravis as a separate disorder. You are making diagnosis of two disorders. So if we get such a case, should we proceed with the thymectomy?
Yeah, possibly if the patient was young, then and if the patient had generalized myasthenia, we would have considered thymectomy.
Because I am very skeptical of AChR positivity, that there are so many false positives nowadays. In this also it was 0.55 and normal level was something like that, 0.5 and 0.6, right?
Yeah, this is 0.66 and normal level
And 0.5. So these can very well be, now the techniques are so sensitive, they can very well be false positive. But giving the clinical scenario and everything, it fits.
Yeah.
But again, so this ophthalmoplegia was because of myasthenia gravis or it was because of Eglon-5 disease?
The supranuclear component of gaze was there. So with the partially intact VOR. So definitely that is due to Eglon-5. And there is no doubt that patient had ptosis, which was fluctuating, and he had diurnal variation. So that is probably due to myasthenia. Even though Eglon-5 has ptosis has been reported with Eglon-5, that is typically a non-fatigable ptosis and does not have any diurnal variation.
So after the current, given the therapy to this patient, rituximab and everything to this patient?
Yes.
He has already received
We
it.
could extubate the patient and The video which we saw is after extubation, and he had stabilization of disease for around 6 months. But then
The only point, Dr. Ashish, I want to put is the unfortunate part is both the disease will respond to rituximab and immunomodulators and the IVIGs and everything. They both will respond.
yes, sir.
My only contention is, suppose we remove that ACHR from that picture. Suppose we say it's a false positive.
Yes.
And second thing, maybe somehow we can explain that this ocular component is also because of Iglon 5. Then I am very reluctant to say that possibly this may be a single disorder. There is a small possibility.
Yeah.
Means
Agree.
patient doesn't have MG, yeah.
I think
Because
we
then we
fully
will have
agree
to
with that.
think about
Yeah, agree. We
thymectomy.
agree with that. Yeah.
Because
Without
then
yet
we have to think
know.
about because at this young patient, it would have been a young patient, possibly we would have just seen the response of rituximab and not go ahead with the thymectomy. That is what I'm thinking of.
What
Thymectomy is
is the
anyway only
onset of
long term.
symptoms for this? When did the disease onset was?
Onset was 6 years ago, sir.
So 73 means around 60, 67, right? Around 67 years of age. It's a very late onset, even if it's a myasthenia, but it's a late onset myasthenia.
Or it may be just a I think, existence, both diseases have come with this.
Mm.
Dr. Ashish wanted to ask one question. Excellent presentation. Iglon, now since you are also in the movement disorder,
Yeah.
some of the movement disorder experts say that Iglon 5 is not very common, maybe in our setup, or because we have been sending a lot in various PSP mimics, lookalikes with some sleep. It doesn't come positive. I mean, how? First question is, I mean, which phenotype you feel will give you a maximum yield of Iglon,
Uh,
and how commonly, Iglon 5 you have been seeing?
we have seen 5 cases here in Chitra in the last 3 years. And most common phenotype would be a PSP-like phenotype. And especially if it is associated with REM sleep behavioral disorder or other sleep disorder. You do not see RBD commonly with tauopathies. So if you
What is the usual duration of the presentation?
usually it is around 21% of patients present with a subacute presentation of less than 4 weeks, 80% present with insidious onset chronic slowly progressive, and mean time from the onset of symptoms to diagnosis is around 36 months. That is 3 years. So if the patient has presented late, then there is a dilemma on like when do we send the antibody or not. But if you have a typical like picture, like if you have PSP with a RBD, or if you have MSA like picture with slow eye movements, then you have to suspect Iglon 5 antibody disorders.
Is
Even patient has
how
presented late.
specific is sleep? Like sleep is present in all the cases, or it is present rarely? Sleep disorder.
In the initial study published from the Barcelona group in 22 patients, 100% of patients had sleep disorders. Later on, from the German study published in Brain article, out of the 53 patients, only around 55% of patients had sleep disorders. So sleep disorders is not necessary for diagnosing.
And as the Vishnu also noted out, and Dr. Rakesh is also asking the question with the same intention, I think, because it's a huge list of the presentations.
Yeah.
And the presentation can anywhere from subacute to chronic.
Yeah.
So now, should we get Iglon 5 in almost all the places? What type of
Yes,
cases
sir.
means
Yeah, that's what I'm saying, sir. So if
testing these antibodies?
patient
Yeah.
has a
What
PSP
cases?
like generally if the patient has a PSP like phenotype and if it is rapidly progressive, or you see atypical features like a REM sleep behavioral disorder in a PSP, then you should definitely ask for Iglon 5 antibody disorder. If the patient has an MSA like phenotype with autonomic dysfunction, all the classical features, but if the patient has cognitive decline or eye movement abnormality, then also you should ask for Iglon 5 antibody disease. If the patient has cognitive decline, which is rapidly progressive, with or without chorea, then you should ask for Iglon 5 antibody disease. If you have myasthenia with fasciculations and or atypical presentations of ALS like sleep disorders with eye movement abnormality, then also you may ask for Eglon 5 antibody disorder. So you
So
need
after today's
for Eglon 5 in all patients, especially if there are some specific signs, specific indications, like I mentioned, then you should go for Eglon 5 antibody
because
disorder.
after watching your current presentation, my definitely rate of sending the Eglon 5 will go up.
Yeah.
And important part is probably Inglon fly is not the reason for giving rituximab or cyclophosphamide in every PSP and MSA patient. So that is that should not be this one. See, so what Ashish has very well summarized all the phenotypes in a tau sleep disorder in a tauopathy or ocular abnormality in a MSA, those kind of atypical cases where these are the cases and a rapidly progressive multi-axial, if you have a multiple systems involvement in a rapidly progressive disease. These are the cases we usually suspect an autoimmune disorder. I mean, as in any autoimmune encephalitis that you suspect they're also there. But unfortunately, we are all want to treat. We are all want to treat neurodegenerative disorders as some amount of neuroinflammation in it, and somehow everyone turns out to be probably Glon 5. So
No, Vishnu, we
that
are
term is
getting
not there. It is something which I have told. So nobody has
no,
discovered
Vishnu,
a probable Glon 5.
we are now getting many cases of PSP with the this dementia-like picture. They are and in any Parkinsonism any type, the sleep disturbances are very common. So that cannot be used as standard because. But I think that's an important clue that if cognition is involved, then possibly we should go it. And PSP usual cause is also 2 years, no, 1 or 2 years only.
I think what Ashish was trying to tell was that PSP having cognition is not a problem, but MSA having cognitive is a problem. And non-synchronopathies having sleep disorders also should be a problem. So it's like a unusual combination of atypical Parkinsonian syndromes. That is, I think, what Ashish was trying to imply.
Dr. Ashish, can you
Ashish,
take, there are two questions in
yes,
the.
yes. So the question is, can this case be screened for malignancy?
Yeah, patient was screened for malignancy. We did not find a malignancy. And Eglon 5 antibody disorder, malignancies are very less common, around 10 to 15% only. And there's no specific association with any particular malignancy. And the PNS score, none of the patients had PNS paraneoplastic score more than 3, indicating that it is likely to be a chance association.
Thank you. And CSF or serum, which one has better sensitivity for Eglon 5?
CSF. If you have a serum, you should definitely go for a CSF study for confirmation. So if you in this patient, both were positive. You generally do as a screening test, we do screening serum Eglon for many patients. For confirmation, we do CSF also.
But I think the higher sensitivity is also for CSF. So if possible, ideally, we would send CSF. No?
Yes. Yes.
Eglon 5 is a spectrum of autoimmune neurodegeneration at extreme end, and neurodegenerative process secondary to autoimmune has to be addressed. I think that's more of a comment than
any classical radiological feature for Eglon 5? MRI or picture, something, any classical thing?
No MRI feature.
No
No classical MRI feature.
Thank you. That is a good comment. And is seronegative Eglon 5 an entity?
That is what I was thinking. I was when this is going to come.
I'm very skeptical about this seronegative MOX and seronegative Eglons and everything. I think till we have a definite criteria for it, this is an overdiagnosis more likely.
No, see, autoimmune disorders, sometimes antibodies come positive, negative at one point in time, the disease might evolve more severe, and later on this makes you more vigilant about it. And yeah.
So,
I mean, overall, it was a great presentation. Very interesting.
Absolutely, man.
Yeah, absolutely.
Too good, just too good.
Usually, I do something else in between. I didn't do anything in between. I was listening to all the 3 cases. So it's very interesting cases. Yeah.
So thank you, Ashish, Gemini, and the IAN group for this wonderful platform as well. Dr. Rakesh in particular, he was following him for everything. So thank you so much for allowing us this opportunity, and my colleagues for their wonderful presentations. So we are late, but before 10 o'clock. So I'll stop at this point. Thank you.
So should we close, Vishnu?
Yes, sir.
So on behalf of IN and Dr. Vishnu and me, We thank Dr. Kriti, Dr. Ashish, and Dr. Jemini for a excellent presentation, and so many new things to learn from conditions like degenerative iglon and anterior horn cell, which can be treated. So a lot of great learnings from this session. We thank Dr. Shruti, and more so because you accepted it at a very short notice, only a few weeks to go, and you said we will be doing it. Thank you so much.
Thank you.
So now the next session will be in the end of last Wednesday of Feb, and we look forward to joining with them. Thank you so much. Good night.
Thank you. Thank you, sir.
Right, everyone.